So I was asked to kind of come up with a case, and we would work through it. I wasn't expecting such a large group, so it'll be a bit interactive. So I'm going to be asking you guys for answers. And then what I've got are slides more just to consolidate some of the things that we're going to talk about together. So I think they distributed the case. So if you don't have a case, the case that we're going to be talking about, you might just raise your hand so that you get a copy of the case. Who's distributing it? Oh, they're coming around. Okay. So just to start, I have no conflict of interest or any financial gain in doing this presentation. And what I wanted to do today was review the roles of ESAS and PPS and ECOG, reflect on some general approaches to symptom management, and then I kind of honed in on one group of symptoms because I could spend an hour on every symptom. You know, on ESAS there's 9 symptoms. I could probably spend an hour on all of them. So I kind of took a case, and we'll kind of work through more some of the GI symptoms that you might experience with cancer patients. So I hope everyone's got the case. So I'm gonna read through the case. So it's Janet Sterling. She is a 69-year-old woman, initially diagnosed with stage 4B serous carcinoma of the uterus with positive omental involvement in January of 2012. She was initially treated with total abdominal hysterectomy, bilateral salpingo-oophorectomy, and then this was followed by 6 cycles of carboplatin and Taxol. So she did well until December 2013, when again she found a recurrence, and now she has bony involvement as well as liver metastases. She had a met to a sacrum that was causing her a significant amount of pain, so she went on to have some radiation to that region, and then continued with 6 cycles of carbo-Taxol, which was completed in June of 2014. In February of 2015, she presented with 2-week history of left-sided clumsiness, confusion, and then was found to have a temporoparietal mass. She underwent a right mini craniotomy for this, and it came back positive as a metastatic carcinoma from her uterus. And then she had radiation following this. And then the radiation was completed now in March of 2015. She actually didn't want to pursue any further chemo treatments, and so she's kind of been on surveillance, and she's been coming to your office regularly. So just from a little bit of background about Janet, she's a widow. Her husband died about 6 years ago. She lives alone, but has a very active group of friends from work. She used to work as a teacher, so she has a good health care plan. And she has 1 daughter who doesn't live nearby. She lives in Calgary. She doesn't smoke, and she only occasionally drinks alcohol. In terms of other past medical history, she's got COPD and osteopenia. So medications. So she's on MS-Contin, 15 milligrams Q88. This was started about 2 weeks ago when she presented to your office with some right hip pain. She's on Statex, 5 milligrams Q1-HPRN, lorazepam, Gravol, Ventolin, and then she also takes some alternative therapies like some Chinese herbal medications. So she's coming to your office today. You came to this lecture and know the importance of ESAS, so you got her to complete that while she was waiting for you. And your nurse hands you the ESAS form. So I think it might be the last page, you'll see what her ESAS form says. So how many of you are familiar with ESAS? Like, how many of you have used ESAS? So a couple of you, yeah. So before we go into looking at what ESAS, her ESAS scores, I kind of wanted to sort of strengthen the importance of why we keep touting this tool for everybody. And so ESAS is a standard tool we're using in our cancer center. So everybody who comes in our doors is actually getting screened. And then this actually goes into our power chart. So if you have access to the hospital power charts, you actually also have access to their ESAS scores, okay? And what we're trying to get family physicians, so even if you look at community nursing, the nurses that are going out to see the patients, they're filling out ESAS every time they see their patients. So it's language that we're going to be using, and language that, your nurse might call up and say, her ESAS score was 8, so you really need to understand how to use it. And so why did we start ESAS? So the first thing we knew is that cancer patients experience a lot of symptoms. And so we know that it's across the illness trajectory. So it's not just people who've got metastatic disease, but people who actually have no evidence of disease also have symptoms, and those with metastatic disease also have symptoms. And you might think that people who don't have a lot of disease might have symptoms, but they're going to be minor, right? Like, everybody's got a headache, and if you screen them, everyone's going to say yes to some of those minor things. But in actual fact, even when we screen patients, we look at severity of symptoms. Patients, even early on disease, will have a number of sort of experience moderate to severe symptoms. So we knew in our cancer centers that we really needed to screen not just those people that we were thinking were palliative, but everybody across the illness trajectory. And so I think those who went to the other, the lecture on survivorship, there's also been studies that look at patients telling us their symptoms. So what we know is that patients don't do a good job. So they don't tell us that they're feeling bad. So, there have been multiple studies. This was just one of them where they found only 1/3 of the symptoms experienced were self-reported. And then 2/3 you actually had to ask a questionnaire. And again, if we look at distress, we would think that, okay, if I had a lot of pain or if I had a significant amount of shortness of breath, of course they're going to tell me. But what we find is that patients actually don't tell us. Only 21% of distressing symptoms were actually volunteered, right? So we know that patients don't do a good job. So just coming in and saying, oh, how are you doing, is not good enough, and that we actually do need to use the tool to actually get this information. And so this was another reason why it's important, is because poorly managed symptoms is the prime reason why patients go to emerge or access other resources. This was a study done, I think it was done locally. This was poorly managed symptoms can significantly alter clinical course of an illness. And what they looked at, it was the odds of going to the emergency room after having a high symptom score. And they found that the odds were much higher if patients with high symptom scores had a significantly higher odds of visiting the ER within 7 days. So we know that symptoms are going to be an important thing for us to manage if we're trying to reduce the number of visits to the emerge department. And so it's a validated tool. It's been used. It's easy to use. Patients actually, we've done many surveys at the Cancer Center. Patients actually like it. It gives them a format to talk to their physicians about how they're feeling. So it kind of gives them a way of expressing themselves. So patients actually really like it. So, but it does have limitations. It's only the top 9 symptoms, right? And it is a screening tool. That's all it is. So someone can come out with an 8 out of 10, but that doesn't mean, you have to go back and find out. So that 8, doesn't necessarily mean that they're having 8 out of 10 pain. We don't know. You have to go and ask to see what's really happening. And I think in the survivorship lecture, they were saying that, sometimes I'll get, screens where everything's 10 out of 10, 9, 8, 7, high numbers. But oftentimes that's a sign something else is going on. That it's not, when you start honing in on the symptoms, that, maybe there's something else, maybe depression, anxiety, and those things are also playing a role. And so the whole thing about this whole routine screening is that we're actually trying to improve patient care, that it actually leads to better detection of symptoms, then we're actually managing them, we're actually referring them to the right resource if they needed to, and then hopefully avoiding those emerge visits. So that's my sort of soapbox preaching on ESAS. And it's a tool that everyone has access to. You can Google it, you'll find it. It's on the CCO website. I encourage you to download it and use it in your practice. It comes in many languages as well, so you can get it in different languages if that's a barrier to your practice. So let's go back to Janet Sterling. So I actually put down, so you've been doing ESAS scores when she comes into your office. So on September 9th, when she came to your office 2 weeks ago, these were her ESAS scores. So her pain was high, tiredness was 3, drowsiness 3, appetite 3. Everything else wasn't too bad, right? And now she's come back. Now, if you remember, I said 2 weeks ago, you started her on some pain medication for this hip pain, right? So you come back. So September, 2 weeks later, her pain seems to be down, but now her other numbers are higher. So what information, so given this is before you're going into the office, okay? You get to see these scores. So what information would you want to inquire about now? Like what are you thinking? Bowel habits, yeah. So so you're thinking that, so what do you? You mentioned about opioids is likely to relax this. So if we look at her med list, she wasn't, doesn't look like we see any there, right? So, but you're concerned that you started on opioids 2 weeks ago, right? And, okay, anything else? Yeah, so it's just her psychosocial support. She lives alone, right? And does she need more help? When you look at well-being, it's a 7, right? So. Mm-hmm. Sorry? So, okay. So is the opioid the thing that's causing the nausea? So it could be constipation from the opioid, but opioids themselves can, some people, depending on, do well with one opioid over another. What other things would you think of? Yeah.
High nausea, appetite issues, so diet, and also the Gravol seems opioid.
Mm-hmm.
To change that
Yeah, so you'd also want to kind of see, she's using the Gravol. How is she using it? What effect is it having? You know, where are you going with that? Yeah. Mm-hmm. And why are you thinking that?
She's tired. She's drowsy.
Yeah. So her fatigue.
Is her pain impacting her sleep?
Yeah. So is her tiredness? That's gone up. Is that related to the nausea and vomiting? Is it related to other factors that might be going on? When you look at the nausea and vomiting, and given her a picture, what other things might you be thinking about? Yeah, so what kind of things? Like anything specific? You said disease, but... So bowel obstruction. Oh, so abdominal metastases. And she's got further disease in her abdomen. What other things about her disease? Brain mets, right? So she's had brain disease before, so we really want to have a look at that. And so what other questions might you ask about headaches and... Mm-hmm. What other, like she's got bony disease, so what other thing should you think about when you see somebody with calcium? So that's the other big sort of thing that you always have to keep in mind when you've got somebody with bony disease. Oftentimes they'll present with just nausea and vomiting, right? So that's a good place to start. I think the other thing is we might want to reassess her pain too, right? I mean, although it looks like her pain is much better, so whatever you did is been good. So that's why this ESAS is helpful, because it also tells you sort of what you did and did it work and what's not working. So you're allowed to, it allows you to compare over time as well. So symptom assessment, so you know, sort of the general rule of thumb is when you get an ESAS and you know nausea and vomiting is high, you're going to go in and you're going to focus on those symptoms. So you're going to do the whole, you know, what makes it better, what makes it worse, and so you get a better picture of what's happening. So let's go on to read about. So you go on to ask the questions. So Janet, I see you have been having a lot of nausea. You rated you at an 8 out of 10 on your ESAS today. Yes, I feel so nauseated, doctor. I don't feel like facing any food at all. The very thought makes me feel ill. If I smell cooking from down the hall, I can't stand it, and I'm vomiting 2 or 3 times a day. I don't know how long I can go on like this. How long have you had the nausea, Mrs. Sterling? Well, I think I've had it for a few weeks, but it's much worse in the last week or so since I've started vomiting. It seems that whenever I try to eat, it gets much worse, and that's usually when I throw up. Does Gravol help? Yes, but just for a while, and I think it makes me tired. What about your pain? My hip pain has been much better since you started me on the morphine a few weeks ago. I take about 2 breakers during the day, and they work well for me. Any headaches? No headaches. Have you had any other symptoms? I've had a troubling cough, but it seems to have gone away lately. What about your bowels? I've been constipated for a few days now. The nurse gave me some Senna. I've used it for a couple of days, but they don't seem to be working. On physical exam, Janet is found to be cachectic. She's ambulating with support of a walker. There's no jaundice or cyanosis. Blood pressure is 100/70, heart rate is 96, and her PPS score is 60%. On head and neck exam, she has no oral candidiasis. There's no other palpable lymph nodes. Her heart exam is normal. Chest exam, she's got some decreased air entry in her right lobe. Her abdomen's mildly distended, bowel sounds are present. She has a mild tenderness on palpation of her right upper quadrant, no mass, and slightly enlarged liver. The rectal exam reveals a large amount of stool. So just on that physical, what are your thoughts? Mrs. Sterling's PPS score is 60%. What are your thoughts on that? Like how is that helpful to you? Mm-hmm. So it helps us gauge sort of what treatments that we might choose for that patient, right? What are the things that you think, if she comes into your office with a PPS of 60%, what are the things that,
Generally hope to improve her above that, but 60 pretty low.
So 60, what 60 means, so this is PPS score, so people who haven't been familiar with it. So I don't know if some of you are familiar with ECOG. ECOG just looks at functional status. So and it rates it from a 0 being totally functional to a 4, right, or 5, 4. So, and then PPS takes it a little bit a step further because it looks at functional status as well as intake and level of consciousness. And so someone who is a PPS of 100 is someone who's got no disease, active, and lives a normal life. Someone who's 50% is someone who's spending sort of 50% of their time sitting or lying down, okay? And then obviously 0 is someone who is dead. So 10% is someone who's actively dying, okay? So that's how, so the, 100, 50, and then 10. Yep. Yeah, so exactly, because what we know about these patients is that, especially in cancer, their illness trajectories are quite predictable. So these are kind of the illness trajectories we see for different types of illnesses. So cancer kind of has this, they're like stable, 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 and then once they start petering down, they go down pretty quick. End-stage organ failure, like end-stage heart, lung, they're a little bit harder because what happens is they go up and down, and they might be up, their functional status might be up here. The trend is still downwards, right? But they kind of do this up and down, up and down. So they're a little bit harder to predict when they're early on. But what you'll find is that these downward trends come closer and closer together, and then they have these sort of sudden death, right? And then dementia is this sort of low-lying, lingering sort of trajectory. So you can see in cancer, it is very, PPS is very predictable. And whereas with dementias, they could be 30% for long periods of time, right? So it's not as helpful. But with cancer, what we know is that if your PPS is 50%, that you have a high risk of dying within 3 months. So you know things are going to start changing, right? So we've got a patient that's 60%, right? So you need to start deploying resources. If that person's not on CCAC, you should start thinking about CCAC. If you haven't had advanced care planning discussions, you should start thinking about having those advanced care planning discussions, because things are probably going to start changing pretty quickly. And so they're actual predictable, we sometimes map out on sort of on the sort of the cancer trajectory, like when their PPS is 70, start having advanced care planning discussions and goals of care. But when you start getting to 60, you want to hone in on those discussions and have more discussions about DNR and sort of specific discussions. And then when you're into 50%, you really want to make sure you've got the resources and supports in place. So it's very important to sort of look at PPS. And in fact, in our cancer center, we're actually now having self-reported functional status. So when patients come in, they're recording their ESAS, but they're also telling us how they're functioning. And so we're using that information. It's more like ECOG, it's not the PPS, but it still gives us information in terms of should we be deploying resources, should we be having some crucial conversations. So it is an important so it's the single most important predictive factor for cancer is performance status and functional ability. If a patient is spending more than 50% of their time in bed or lying down, the prognosis is estimated as 3 months or less. So, and that's ECOG, so it's 0 to 4. So Janet Stirring, let's get back to her. So she's got a PPS of 60%. So we do want to have some crucial conversations with her. We want to make sure we've got some advanced care planning in place. We probably want to have the DNR discussion. We want to get CCAC involved, even if it's just introducing a nurse or having some, if she needs screening to see if she needs actually PSW support. And so then it's, what are some of the possible causes for her nausea? So what are you guys thinking? So morphine, so are you thinking morphine causing the nausea? Or are you thinking morphine side effect, like, constipation causing? Okay, sure. But you'd manage them differently, eh? Like you would manage, if you think it's the morphine, you would manage it differently versus if you thought it was constipation. So what are your thoughts on, so how would you make a decision? Because are you going to switch her morphine at this stage, or would you? So. Sorry? You don't?
Because of also having the fatigue and the nausea, just being in the back of my mind thinking if I need to switch.
Yeah. So fatigue and morphine, doesn't necessarily cause fatigue if we're using it for the right things, sort of thing. So, in fact, sometimes we find people actually do better because their pain is controlled, so they're functionally more better, right? So, if I'm going to switch an opioid, the fatigue probably will stay the same. Like, I don't know if that would alter it. But the nausea, definitely, if we think it's opioid-induced nausea. Usually opioid-induced nausea, you can get it in the first few days, but then it resolves. And if it's not resolving, then you kind of want to think about, do I need to switch to another, if you think it's that. But I agree, I think you need to clear the bowels first, and then look at and see if you get improvement before I would be switching an opioid at this time. Would you do any investigations? Yeah? Yeah, so you might do some blood work just to make sure that we're not missing something. So on this visit, do our calcium level. Yeah.
You make
Mm-hmm.
So they could be treated.
Mm-hmm. So, yeah, because we could get radiation again, right? Depending on what's happening. Yeah. And you might want to say, okay, let's try some of these things that are easy, see if we get an improvement, and see her again in a couple of days. If we're not getting improvement, would there be a high suspicion? Maybe we then kind of revisit that, right? Like in terms of a CT scan. Anything else? So I was just going to sort of go through some of the common causes for nausea and vomiting. You guys kind of came up with most of them. So nausea and vomiting are actually two distinct sort of symptoms. You can be nauseated and not have vomiting, and you can vomit and not have nausea. And it's important to distinguish the two, because you can have someone who eats and just kind of vomits, doesn't have any nausea related to it. You might treat that very differently than someone who has a sort of prolonged nausea and then kind of vomits, right? Your treatment options might be different. In advanced cancer, prevalence is up to 68%, so it is a common symptom. And usually the cause for nausea is multifactorial. So it's not just one thing. So again, the opioids might be doing it, constipation, maybe there's some hypercalcemia, right? So you always, even though you kind of have a high suspicion of one thing, you got to keep your mind open to some of the other causes. And so when you're looking at causes, I kind of divide it for nausea into sort of GI, vestibular, and then brain. And brain, there's kind of two centers in the brain. There's the vomiting center, and then there's the chemoreceptor trigger zone. So you kind of have to look at both. So your GI causes constipation is what we've been thinking about, motility, obstruction. Oral candidiasis is another big one that we see. So you always want to check their mouth. Brain, and drugs are the other big one. So we mentioned the opioids, but NSAIDs, some of the chemos, obviously, and then hypercalcemia is our other big one that we see. So I feel so nauseated, doctor. I don't feel like facing food at all. So what are you going to prescribe for her? So. Come on. What's that? Treat her thrush? Okay, sure, yep.
Do you have any results on any blood tests?
She's not hypercalcemic. Yep.
She constipated still?
Yep. So she's still constipated. Yeah. What's that? So you're going to give her PEG, right? Okay. So you're going to say, so your prescription would be PEG once a day, twice a day. What are you going to? Right. So you're going to, because she's already been 3 or 4 days without, so you want to start from the bottom and get it out. Yeah. And so you're going to tell her to do, and then what are you going to tell her?
I usually say 1 to 5 doses per day as required for soft stools, but at the beginning, more frequently every hour until there's a result.
Okay, so you give her the enema, she has a result, and then you're going to give her, so you're going to say 1 to 5.
Yeah,
Okay. Anybody else? Any other drugs? Yeah?
I usually give her more Ceftides. She's under 5 pills on the stimulant, so I would dose her for rest of the carryover, and then she might get some off.
And then, and would you, so your drug of choice would be Senna?
Yeah.
Yeah. Yeah.
I'm talking.
Yeah.
and an antiemetic of some sort. I probably use my app to figure out what but I got Rachel here, and she suggested I try some antipsychotics over the longest.
So you're thinking Haldol? Is that what you're thinking when you say an antipsychotic? Oh, it's okay. So you're going to treat the constipation, but you're still going to give her something for nausea until that kind of gets settled. So we're going to do 2 things. We're going to treat the constipation and give her nausea. Your choice would be to do Olanzapine maybe. And why would you choose olanzapine over?
Because I told her.
So why are you choosing it?
Oh, we're finding, find with opiate-induced nausea, we found we have better effect with the low-dose Haldol, and then there's been recent studies looking at olanzapine and the low-dose QHS actually has a triple effect where you can help them get better night's sleep, treat their nausea, and sometimes help them with appetite improvement.
So you're trying to, kill 3 birds with 1 stone, right? So that's good. Anything else? Any other sort of things that others would do?
Would you do feet enemas? That hot spool?
Yeah. I would, a suppository or an enema. You know, oftentimes when people are already constipated, trying from above is takes longer, right? And when you're already uncomfortable, the fastest way of dealing with it is from below, right? So oftentimes I will say, and it's different. Some people will refuse, right? Then you're like I think what you're saying, load up, right? Like you're going to load up and then give it. But you know, when you're already nauseated and stuff, it becomes pretty hard to do that. So that's why sometimes you have to go from below. Yeah.
I like the olanzapine idea, but I would usually use protocol instead.
The Steroids.
And I usually dose it steadily, and then just leave the Gravol
Mm-hmm. So you just give it PR. You would say you would give her a statin. So your strategy. I'm going to give her a statin.
And a fleet,
Yeah.
and then I would add some steroids on top of stuff on a regular basis. And that was one thing I don't
Okay, so Stemetil, then maybe Ondansetron, and then maybe you're open to the olanzapine. Sounds good. Okay. So actually, when we look at nausea, there is a strategy, right? So there's a strategy. So there's 2 things here. There's management of bowels, and then there's the management of nausea. So I'll start with the management of nausea. So you guys are on the right track. So there is a strategy. And the thing about nausea, it's easy because you just need to know. So you kind of got to think about what the cause is, and then look at what the pathway is, and then you can pick your drug. Okay, and so when I'm talking about this, I'm talking about this sort of diagram. There's really 4 pathways. There's the vomiting center, the gastrointestinal tract, the chemoreceptor trigger zone, and the vestibular apparatus. And then, of course, the brain cortex, which is anxiety. You know, those things also affect nausea and vomiting. And so each of those sites has specific receptors. And so, for example, if it's someone that we're thinking it's constipation, we kind of think it's more gut related, right? We might want to look at dopaminergic or a 5-HT3 antagonist, right? If it's something like hypercalcemia, right, that's going to affect the chemoreceptor trigger zone. So again, the dopamine and 5-HT3. If you look at the diagram, I always say, when in doubt, dopaminergic, right? Because it crosses 3 areas, right? So when in doubt, and it's probably less expensive than the 5-HT3, right? So you need to sort of keep this in mind when you're actually thinking about what drugs you're going to choose. And then you have to revisit it. So if it doesn't work, you kind of have to go back to this and say, okay, if I tried the dopaminergic, maybe I need to add a 5-HT3, or maybe I need to switch to a 5-HT. Because if one doesn't do well in one, you kind of have to look at where you're dealing with and then pick your drug.
What do you mean by dopaminergic? What drugs are you?
So Haldol, Stemetil, metoclopramide, so antidopaminergic.
Haldol is disappeared.
Oh, it's back in business. It's back in business. In fact, we use it. It's my first line, actually.
Yeah, it just disappeared about a month ago because all my psych patients I had to take them off Haldol because the pharmacy wasn't supplying it.
You know, I think maybe you guys use it for psych. It's used at much higher doses, and we're using it at 0.5 to 1 milligram, right? So we're using it at much lower doses. So it might be the size of the dosing is missing, because we haven't had any problem with accessing Haldol. So the approach to nausea and vomiting, you want to identify the most likely cause. You want to treat the underlying cause. So if it's hypercalcemia, you want to treat it, but at the same time, you want to treat the nausea. So again, we're thinking it's constipation, so we're going to treat the constipation, but we still have to give her something for nausea. So ID the pathway and the neurotransmitters you think are going to be involved, and then choose the most potent antagonist. And then choose a route, because if someone's got severe nausea and vomiting, you're going to pick a drug that maybe is injectable, right? So you always got to keep that in mind in terms of what drug you're choosing. Is can they take it orally? Do I need to look at another sort of formulation? And then you're going to titrate the dose. So if you start at Haldol 0.5, it's not working, you're going to titrate the dose. But if you think it's not working, then you're going to reassess, maybe add another anti-nauseant or switch to another anti-nauseant in another class. Yep.
If you're using something dopaminergic, and how do you watch, or how closely would you watch them for delirium?
So it's the extrapyramidal side effects that you're concerned about, right? So for Haldol, we don't see a lot of it, I'll be honest with you, because we're using it in such low doses. So with psych patients, you see a lot of it because they're at such high doses. The drugs that actually I see, we see a little more of it is with Stemetil, right? I've had multiple patients with Stemetil, and metoclopramide is the other one, right? Domperidone and metoclopramide. So you have to, so that's coming up, that you actually have to keep an eye on that. And they don't present often with obvious extrapyramidal side effects. Often it's agitation. They get on these drugs and they feel restless. So with metoclopramide, I've had a number of patients that come back and they started on it and they just feel restless. And so sometimes it's screening for restlessness because it's subtle. Sometimes the guy that comes in with his head turned is pretty obvious, right? But the ones I've seen it most in is metoclopramide and Stemetil, right? I don't see it, and that's why I probably tend to use Haldol a bit more because I don't see it as much Haldol. So the drugs that we've been talking about are the antidopaminergics, and they're classed into two categories. There's the pure antidopaminergics, and then there's the ones that have prokinetic properties and are antidopaminergic. And then there's the 5-HT3 antagonists, so that's our Ondansetron, Granisetron. Antihistamine is our Gravol. Anticholinergics are scopolamine. And then others that kind of don't fall in is steroids, right? So we often use that for nausea as well. And antihistamine and anticholinergics are kind of in that vestibular sort of area, and that's why we don't use Gravol a lot, because really it's not in any of the sort of pathways that we're dealing with when it comes to cancer patients. So it's a very low yield for you. You're going to do better doing an antidopaminergic drug, right? So I said the first class is the antidopaminergic and prokinetic. So these are the pushers. So these are good for opioid-induced nausea, right? Because your bowels are getting sluggish. This is actually going to kind of activate your bowels. So they tend to work more on upper GI motility. And so they also help with those patients that are nauseated, but they're feeling like, when I eat, I feel full, like I can only eat small amounts. So when you're reviewing somebody with poor appetite and you're asking questions about, what's it like to eat, and they say, okay, I'm eating, small amounts, and then I feel full, and then I can't eat anymore. They might be individuals that you want to look at sort of metoclopramide and domperidone for. And this is probably in the UK, they use metoclopramide all the time. That's probably their number one, whereas I find here we tend to use Haldol a lot more. Domperidone, just within the last couple of years, anybody who's over the age of 60 has a high risk of cardiac arrhythmia, so we've kind of started reducing the doses. So I used to give it QID, like half hour before meals and bedtime, but now we're going to TID. Domperidone, you have less EPS, right, because it doesn't cross the blood-brain barrier as much as metoclopramide. But I use metoclopramide more than domperidone because it comes in injectable, right? So it comes in multiple formulations. So you'll find us using it a little more just because it's easier. Sometimes if someone's nauseated, it's easier to give, right? Haldol, so Haldol is probably one of my number one drugs that I use for nausea. And we're using them at very low doses, so 0.5 to 1 milligram every 4 hours, right? So EPS is very uncommon. I haven't seen anybody in my practice with EPS, where I have seen it with Stemetil and metoclopramide. And it also is not as sedating, so like Gravol sedating, methyltrimeprazine is another sort of antidopaminergic that's very sedating. So it's actually a good drug. Stemetil or prochlorperazine is also dopaminergic, so it's used a lot in the cancer centers. It's a good drug. Some people like it, some people don't. Like I said, I tend to use Haldol just because Haldol also comes in other formulations. So you can give it sub-Q, you can give it oral, right? So, and Stemetil, I just tend to see a little bit more EPS. I have seen, so I just don't use it that much. Nosenan or methyltrimeprazine, these are sort of some of the new atypical, is also a good drug. And it's good, it has strong antidopaminergic effects, but it also has, there's a number of other receptors like 5-HT1, 5-HT2, so it has a broad spectrum, so it kind of works on a number of sites. The only problem is that it's very sedating, right? So I use it more third line, like if we're having, like, so for more intractable nausea, that's when I would probably start using it. And so olanzapine, so that's sort of the new up and coming, what everybody's sort of trying out. We haven't had, the big studies haven't come out in terms of, how it compares to some of the other drugs. But some of the case reports and is saying that, they are showing benefits of it. And I think because it does a couple of things, right? So it's kind of kills 3 birds with 1 stone. And it has fewer EPS symptoms as well. And it's easy, right? So it's just a wafer that you can. And I don't know if is it covered? Is it? Because that might be what. Okay. Your 5-HT3s are your Garnicitron, Ondansetron. You want to be careful because that causes constipation. So in a patient like the one we have, we're going to give her something for nausea, and we give her this, and it's just going to cause more constipation and stuff. So her, I probably would give either metoclopramide, is probably would be my first choice. And so this is used mainly with chemo, but I do use it, like my first line might be a dopaminergic, and then if it's not working, I might add or switch to one of these drugs. And now they're cheaper too, right? So, and they're more available. So. Antihistamines, really in our world, we don't have a huge role for them, right? So Gravol, really, I mean, it's always ordered in the hospital, but it's probably the last thing that's really causing their nausea, right? It really shouldn't be our standard first line treatment for nausea and vomiting, because even in hospital, like, you're usually there with metabolic or other problems that really an antidopaminergic would probably be better. Scopolamine or anticholinergics are other drugs that, again, I use them more if I've got intractable nausea. Anticholinergics work in the vomiting center as well, but they've got a lot of side effects like dry mouth, so not always great to start with. So. Any questions on those drugs or?
We kind of live in this stage of marijuana mania, and our patients are, usually it's not us, usually our patients requesting it for all kinds of things, including stuff like this.
Mm-hmm. Yeah, so cannabinoids. So before, I don't know if I can go back. Oh, I did something. Oh, it's back. How do I go back and forth? Oh, there's no way of going back. Well, I can talk to it anyway, but well, actually, I probably do need to go back. Oh, do it from the computer. So so we don't know how cannabinoids work, right? There have identified some receptors in the brain stem that might suggest sort of an action. They're not really marketed, so they are being marketed for chemo-related nausea, right? So, but the studies actually don't show that it's any better than some of the other drugs. So the 5-HT3, right? It's one of those, and a lot of people don't like the effects of it. Do I prescribe it? I find that people who like it, right? So there's a certain group that kind of, I don't go, if someone comes to me and saying I'm nauseated and, what do you think about cannabinoids? I would say, okay, what have you tried first, right? And if we've tried things and they're not really happy with it, then I'm open to doing it, right? But I find, especially the elderly population, they don't like the way it makes them feel. So your options are to smoke it, eat it, and then we've got the pills, right? And so I tend to prescribe the pills. If we're going to use it for nausea, let's do it, right? And again, it has some other added benefits, appetite, and for some people, it helps with well-being. For some people, it doesn't make them feel better, right? So that's the issue with it, right? So steroids are the other one. We call steroids vitamin D at the Cancer Center. When in doubt, give a little bit of steroid. Makes everybody feel a little bit better, right? So, so we use steroids obviously before chemo because the studies show that it actually enhances the effect of the 5-HT3. Again, we're not really sure how it works, but it has a, when you're looking at some of the causes, it does have a place like anti-inflammatory. So if you have a mass, for example, that's causing pain, I'll often use it. So if you have a GI mass, like some of these ovarian cancers that have peritoneal seeding, sometimes I'll try a bit of Dex just to see if that helps, if they're having intermittent obstructions and stuff. I tend to limit Dex for latent disease though, right? Because Dex has a lot of side effects. So I'm not necessarily going to put someone who's just been diagnosed with cancer and who's got nausea and vomiting, I'm not necessarily going to be putting them on Dex, right? So if I do, it'll be a very short period and I'd be tapering them. I wouldn't be putting them on long term. And then the newer ones are the NK receptor antagonists, Amend and Prepotent, and they're used mainly for the chemo-related nausea, so we don't have access to those drugs. But just so you're aware that your patients might be getting that in the cancer centers. And then obviously you're going to look at non-pharmacological, ginger, acupuncture, acupressure. Some people find that very helpful. Eating small, frequent meals. Dealing with smells related to necrotic tumors and stuff. So I guess when it comes to treatment, we want you to identify the underlying cause, know the pathway that you're thinking that you're working on, and then pick a drug, right? And with opioid-induced nausea, metoclopramide or domperidone or like a dopaminergic, but the metoclopramide because again it's got the prokinetic piece to it. For chemoradiotherapy, obviously the 5-HT3s. And if the symptoms persist, you're going to review. You're going to look at okay, if I use a dopaminergic, maybe I need to try a 5-HT3 antagonist. If that doesn't work, or maybe I need to do them in combination. So does anybody have a strategy with constipation? So like we threw out a bunch of drugs. So are there any drugs that are better? Like you mentioned Senna, that's your drug of choice. And that's because it's a stimulant. And you like PEG, and that's an osmotic, right? So, yeah, so Biscotol would be sort of in the same category as Senna, so it would be a stimulant. So there's stimulants, there's osmotics, there's softeners, which is kind of a misconception, I think. Lactulose. So lactulose would be an osmotic, yeah. So, but how do you decide? Do you think one is better than another? Like,
obviously, because the opioids, you use the senna because the opioids kind of make the bowel lazy, right?
Yeah, so you want to get it, so in your mind you're thinking, okay, let's do an activator. So, so actually the studies show, there haven't been any studies, or I don't know if it's lack of studies, so there is no evidence to support using one over another, right? But intuitively, like I would agree, intuitively, I would use probably a stimulant, you know, for opioid induced, because it just makes sense, but we don't really have any evidence to support that. So a couple of things about constipation. I'm going to talk really fast now. So, that constipation can be sort of misdiagnosed, right? Because oftentimes people will come in, oh, I'm having a bowel movement every day, but they're only having small stools, right? So they're still constipated. So you really do need to sort of ask questions regarding that. And oftentimes, sometimes people will have impacted stools that will present with diarrhea, right? So you want to kind of avoid that. And then you want to rule out some of the emergencies like hypercalcemia, spinal cord compression, or bowel obstruction that might be causing it. So always have those sort of in the back of your mind. So these are kind of the sort of drugs of choice that we have, and they kind of go from predominantly softening to predominantly stimulating, and then there's the in-between, right? And so there's lubricants, there's the bulk forming osmotic stimulants. And none are, so what I say is pick your drug that you like working with, right? And work with it, and then use it. And if it's not working, add something from another class, right? So if you're using senna, it's not working, then add an osmotic. So add PEG. Or if you're using PEG and it's not working, I would add a senna. So there are certain drugs though I would avoid. Okay, so one is Metamucil, right? Because those bulk forming drugs actually in cancer patients tend to increase constipation, because you have to drink a lot of fluid in order to make those work, right? So I wouldn't give anybody Metamucil. Mineral oil, I used to love mineral oil. I still do. I don't use it very often, because if you're really looking for a softener, that is the really only softener out there. But it affects the absorption of other drugs, so you have to be really careful. And with elderly, like anybody who's at risk for aspiration, right? So anybody who's later in disease, it's kind of very high risk. So I actually stay away from it, so I don't use that at all. And then Colace, so Ducasate. So that used to be, I remember when I was in residency, it used to be like Cascara, and you know, there used to be the 2 combo you used to do. And now what the trend now is Senocot and Colace, right? That's the new combo. So anytime you go into a hospital, that's what they're ordering, Sena and Colace. And there's no evidence that Colace actually does anything. And so if you looked at my last diagram, it's the middle of the road, right? So it's not a good stimulant, and it's not a good softener, right? And so the studies where they looked at Senna, they combined Senna with Colace, they didn't find that there was any difference. So we're moving away from prescribing that combo. I would do PEG with Senna, like I would do that combo over Colace. Now there's people who swear by it, so if they come with it and they love it, I'm not taking them off it. Some people like it, right? So, but it's not something that I'm like prescribing myself. If they're on it, they're on it, but it's not necessarily something that I would prescribe. So, so the other thing about stools, I actually do a bowel regimen, okay? Because these patients are high risk for constipation, so on the opioids. So, you know when we were talking about the enema, and then you're saying load them up, I actually give them an actual regimen. I will say, day 0, no bowel movement. No, day 0, you have a bowel movement. Day 1, no bowel movement, increase to Senna. Day 2, no bowel movement, enema, right? Like, so they have actually, and then if I see that they're getting an enema every 2 days, I need to increase their regular laxative. So you can get them to see their own patterns and then start increasing their drugs, right? And you'd be surprised at how helpful that is, because I think people get lost when it comes to the bowel meds. They're kind of on it, and then they don't know what to do when they get constipated. Then they're like taking a whole whack, and then they get diarrhea, right? So you kind of want to. I'll just briefly mention methylnotrexate, because that's been out for a while. And so it's an injectable that you give every week to have a bowel movement. So it's a peripheral opioid receptor antagonist, and it doesn't cross the blood-brain barrier, so it doesn't affect sort of the pain. It doesn't block sort of the pain issues, but it goes to the gut and sort of helps in that area. I don't use it a lot. I've probably only used it maybe a couple of times. And it's expensive and it's not covered. So that's one big barrier to it. And the other thing is that there's a risk of bowel perforation, so I'm very sensitive. Anybody who has any bowel disease, I kind of stay away from it. Like I won't use it in anybody who's got so in this patient I would never use it, right? Because there's a risk for bowel perforation. So if they've got any obstruction, and if they're filled to the poop up to here, you know how you get those patients that haven't had a poop in 10 days and you just got to clean them out, I still probably wouldn't use it at that stage. I would use it more as a regular, you know what, they can't take oral pills, they don't like taking oral pills, I would give it to them sort of by injection every 3 days, but I wouldn't treat that. And it's only effective in 50% of the patients because constipation is multifactorial, right? So opioids is not the only cause of why they're constipated, so it's not always that helpful. So I would give it a try, and if it works, then I would do it every week, or how many ever times they want a bowel movement in a week. And then if it doesn't work, I would move on. So I think I'll stop there. I was going to talk a little bit about bowel obstruction. Yeah, I'm stopping. Any questions or?